Nós vamos passar agora para o nosso simpósio Satélite e a gente precisa fazer um grande agradecimento ao nosso patrocinador Gencell Pharma, que nos apoia nesse evento, apoia o Câncer de Mama Brasil nessa tarefa de fornecer educação médica continuada de qualidade para nós médicos e também levar informação médica precisa e ampla para pacientes e o público leigo em geral, o que certamente auxilia muito nos resultados de assistência e resultados oncológicos que a gente tem hoje. Nós vamos ter a palestra da doutora Josephine Lopes Cardozo, da Holanda, e ela vai falar sobre o outcome of patients with an ultralow risk 70 gene signature in the MINDACT trial, que é os resultados de pacientes com assinatura genética de 70 genes ultralow no estudo MINDACT. Então vamos passar agora então a apresentação da doutora Josephine.
A medical fellow at ERRTC. I would like to thank the organizing committee for inviting me to speak at this symposium. Today, I present our research on the outcome of patients with an ultra-low risk 70 gene signature in the MINDACT trial. I have no conflicts of interest to disclose. Since the introduction of the National Breast Cancer Screening Program in the Netherlands in 1990, there has been an increase in the incidence of breast cancer. There has mainly been a large increase in the incidence of small, early-stage breast cancers, but almost no decrease of large tumors. At the same time, we have seen an increase in the 10-year survival for all stages of breast cancer except stage 4, due to adjuvant systemic treatment, mammographic screening, and improved local regional treatment. The 70 gene signature is one of the gene signatures that has shown level 1 clinical utility to identify patients with a preserved outcome when treated with adjuvant endocrine therapy and no chemotherapy through the large prospective phase 3 MINDACT trial. The 70 gene signature identifies patients at low or high risk of distant recurrence within 5 years of breast cancer diagnosis. In 2017, a threshold for ultra-low risk was defined, representing breast cancers with 100% breast cancer-specific survival at 15 years in independent validation cohorts of the 70 gene signature. We know that patients with ultra-low risk tumors, according to the 70 gene signature, have excellent survival in historic cohorts. Here you see the validation cohorts which were used to set the threshold for ultra-low risk. In these cohorts, 98% of patients received no adjuvant systemic treatment. The breast cancer-specific survival at 15 years was 100% in ultra-low risk patients. In another study, the historic STO3 trial cohort was analyzed. In this study, patients with lymph node negative disease smaller than 3 centimeters were randomized to receive tamoxifen or no adjuvant systemic treatment. Of the patients for whom a 70 gene signature could be done, 339 received tamoxifen and 313 received no adjuvant systemic treatment. In this cohort, patients with ultra-low risk tumors had excellent 20-year breast cancer-specific survival. 97% for patients who received tamoxifen and 94% for patients who received no adjuvant systemic treatment. However, in both these studies, the number of patients with ultra-low risk was small. 2 studies have shown that tumors with a low and ultra-low risk tumor biology, according to the 70 gene signature, are overrepresented in screen-detected cancers. On the left, a cohort of patients from before the introduction of screening was compared to a cohort of patients from when after widespread screening was adopted. They found that there were significantly higher proportions of patients with low and ultra-low risk tumors in the screened cohort, as indicated in gray and blue, compared to the cohort from before screening was introduced. We found similar results when we looked at the patients that were included in the MINDACT trial, the Dutch patients that were included. We found significantly higher proportions of low and ultra-low risk tumors in patients with screen-detected cancers, as indicated in green, compared to patients whose tumors were found in the interval between 2 screening rounds. In this cohort of Dutch patients included in the MINDACT trial, we evaluated if there was a difference in outcome based on the 70 gene signature within screen-detected and interval cancers. We know from previous studies that screen detection is associated with a better prognosis of breast cancer, independent of known clinical pathological characteristics. The cohort of Dutch patients included in MINDACT were linked to the National Screening Database of the Netherlands. 754 patients had screen-detected cancers that were mammographically detected by screening. 348 patients had interval cancers, which were symptomatic tumors diagnosed within 24 to 30 months after a negative screening. We found in both groups that patients with 70 gene signature low and ultra-low risk tumors had more favorable clinical pathological characteristics than patients with high-risk tumors. Similarly, patients with screen-detected cancers had more favorable characteristics than patients with interval cancers. With a median of 8.6 years of follow-up, we evaluated distant metastasis-free interval, defined as the time until distant metastasis or breast cancer-related death. Within the screen-detected cancers, all patients had excellent survival and no statistically significant difference was observed between 70 gene signature groups, with distant metastasis-free interval rates ranging from 94 to 98%. Within the interval cancers, there was a statistically significant difference between 70 gene signature groups. For the low-risk cancers, the 8-year distant metastasis-free interval rate was 92%, and for the high-risk cancers, this was 85%. Both method of detection and the 70 gene signature were found to be independently associated with distant metastasis-free interval in a multivariable Cox regression model after adjustment for clinical pathological characteristics and treatment. What we can also appreciate from these plots is that within the 70 gene signature high-risk patients, there is an almost 9% difference in distant metastasis-free interval between screen-detected and interval cancers, despite both being of a 70 gene signature high risk. This suggests that the method of detection is an additional prognostic factor in this subgroup. Furthermore, patients with ultra-low risk tumors had excellent outcome, regardless of their method of detection, although again, the number of patients is small. Therefore, for this project, we had the following objectives. We wanted to assess the survival outcomes of patients with an ultra-low risk tumor biology included in the entire MINDACT trial and investigate if the identification of an ultra-low risk subgroup can help to avoid overtreatment in early-stage breast cancer. MINDACT included women with operable invasive breast cancers that were a maximum of 5 centimeters in size, with 0 to 3 positive lymph nodes and no distant metastases. In MINDACT, patients were stratified by their clinical risk based on clinical pathological characteristics and by their genomic risk based on the 70 gene signature. Patients with concordant low-risk results received no chemotherapy. Patients with concordant high-risk tumors received chemotherapy. The two groups with a discordant risk stratification were randomized to follow either the clinical or the genomic risk to receive chemotherapy or not. Of the 6,693 patients included in the MINDACT trial, profiling revealed an ultra-low risk 70 gene signature in 15%, in 1,000 patients, which is 15% of the whole population. Around 95% of the low and ultra-low risk patients had hormone receptor positive, HER2 negative breast cancers, compared to 57% of the high-risk patients. 76 to 85% of the low and ultra-low risk patients received only endocrine therapy or no adjuvant systemic treatment, whereas 83% of the high-risk patients received chemotherapy. The median follow-up in this study is 8.7 years. Our primary endpoint is distant metastasis-free interval, which is defined as the time until distant metastasis or breast cancer-related death. Patients with low and ultra-low risk tumors had very good distant metastasis-free interval rates compared to patients with high-risk tumors. The 8-year distant metastasis-free interval rate of patients with an ultra-low risk tumor was 97%, which was 2.5% higher than patients with low-risk tumors. In a Cox model, the risk of distant metastasis or breast cancer-related death was significantly lower for patients with an ultra-low risk tumor compared to low-risk tumors, with a hazard ratio of 0.65, although confidence intervals are wide. When assessing breast cancer-specific survival, the difference between patients with low and ultra-low risk tumors becomes smaller, with excellent 8-year survival rates above 98% for both groups. The 1,000 patients with an ultra-low risk 70 gene signature had favorable clinical pathological characteristics. 2/3 were older than 50. Around 80% had lymph node negative disease and tumors equal to or smaller than 2 centimeters. 96% were grade 1 or 2 tumors, and 97% were of the hormone receptor positive HER2 negative subtype. 16% of patients received no adjuvant systemic treatment. 69% received endocrine therapy, and 14% received chemotherapy. In addition to a stratification based on genomic risk, patients in MINDACT were also stratified according to clinical risk based on their clinical pathological characteristics. Of the 1,000 ultra-low risk patients, 741 were clinical low risk and 259 were clinical high risk. Clinical high risk tumors were more often of larger size, higher grade, and lymph node positive. When we assess the distant metastasis-free interval in ultra-low risk patients stratified by clinical risk, we see that patients with clinical high-risk tumors have slightly lower rates than patients with clinical low-risk tumors, but the confidence intervals overlap. The absolute difference in distant metastasis-free interval at 8 years is 2.6%. When assessing breast cancer-specific survival, we observed a very low number of events and no statistically significant difference between clinical low and high-risk patients. Both have excellent breast cancer-specific survival rates at 8 years, above 99%. We also investigated whether the distant metastasis-free interval was different according to the adjuvant treatment that patients received. We observed that patients who received no adjuvant systemic treatment or endocrine therapy only had excellent distant metastasis-free interval rates. Of these patients, 97% and 83% had clinical low-risk tumors. The distant metastasis-free interval rates of patients receiving chemotherapy was 2 to 3% lower. However, 92% of these patients had clinical high-risk tumors. In a Cox model, in ultra-low-risk patients, there was no statistically significant effect of treatment on the occurrence of distant metastasis or breast cancer-related death after adjusting for clinical pathological characteristics. In conclusion, patients with an ultra-low risk 70 gene signature have an excellent prognosis with 8-year breast cancer-specific survival rates above 99%, regardless of clinical risk. Very few patients develop distant metastasis with 8-year distant metastasis-free interval rates ranging from 95 to 98%. Furthermore, we observed excellent distant metastasis-free interval rates for the 84% of ultra-low-risk patients who received only endocrine therapy or no adjuvant systemic treatment. Our results confirm previously published results of excellent survival for ultra-low-risk patients in the largest cohort to date. As we know that especially in low-risk breast cancers, recurrences occur very late, longer follow-up will reveal whether the excellent prognosis of the ultra-low risk patients continues, as was seen in the other studies on ultra-low risk. The clinical implications of this research are that we can confirm that the 70 gene signature can identify patients with an ultra-low risk of recurrence, and that these patients could be candidates for further de-escalation of treatment, thus further reducing overtreatment and the risk of side effects. I would like to thank everyone involved in this research, especially Laura van 't Veer and the NKI team, Caroline Drucker, Marjanka Schmid, and Emiel Rutgers. I would also like to thank all MINDACT teams and clinicians and all patients who participated in the MINDACT trial. Thank you very much for your attention, and I'm happy to answer any questions.
Thank you very much, Dr. Josephine, for such a nice presentation. We are sure that this new technology of genomic signatures is a great help for us to select patients for therapy. And it's very interesting to see how this tool can identify patients with such a nice prognosis. And I wonder, because most of the patients that we would use the MammaPrint signature to select therapy, they would be in the category of high clinical risk, which was a small fraction of the 1,000 patients that you just presented. And when you're talking about de-escalation treatment for those patients that usually in the low risk, we would avoid chemotherapy, so they would only get endocrine therapy. So do we have enough confidence to even de-escalate the endocrine therapy in this cohort of patients of ultra low risk in the MammaPrint signature?
That's a very good question. You are indeed right. Like the question of MINDACT was to see if we could de-escalate chemotherapy in patients with clinical high risk and a MammaPrint low risk. The ultra low risk category is actually a completely different group. And I think it would be interesting to see if in the clinical low risk patients that are also MammaPrint ultra low, if you could de-escalate endocrine therapy. Right now in MINDACT, we only had 16% of patients that received no adjuvant systemic treatment at all, so no endocrine therapy. They are mostly Dutch, as in the Dutch national guidelines, there is a small group of patients for whom you can forgo endocrine therapy as well. And we see that these patients have an excellent survival at 8 years. However, of course, we also know that patients who receive endocrine therapy have lower rates of contralateral breast cancer and local regional recurrences. So your endocrine therapy does not only work on your distant metastasis. I think for now, the amount of evidence for completely leaving out endocrine therapy is not high enough based only on the results from MINDACT. Although they do confirm what was seen in the earlier trials, such as the STOW trial, and there half of the patients did not receive any endocrine therapy. There was a randomization between tamoxifen or no endocrine therapy. And there you see also for this ultra low risk group, an excellent 20-year survival. So it's probably possible, but I think the results from this study will help to design future trials into the de-escalation of endocrine therapy, specifically in this low risk group.
Nastim, we have some questions here from our audience. Dr. Felipe Zeves is asking you, if we have a patient that are taking endocrine therapy and are referring a lot of side effects, do you think that would be a good indication to do the MammaPrint signature to see if this patient would fall in the ultra low category, and then we can withdraw with more confidence endocrine therapy? Does it open a new possibility for this indication?
I think it does. I think that is one of the patient groups where you could use the 70 gene signature at the moment. Of course, we know that a lot of patients experience side effects, and we are probably treating a lot of patients who don't really benefit from endocrine therapy, but we don't know who these patients are. and using the 70 gene signature to identify this group of patients with an excellent long-term prognosis, also without endocrine therapy, could be helpful. So indeed, if you have a patient who is experiences a lot of side effects, they are probably going to stop early anyway. So if you can confirm with the 70 gene signature that indeed this patient has an ultra low risk, then it can be, you can tell the patient to stop with a little bit more of a rested heart.
And you, as a segue of this question, and I think you have already answered this question. Eduardo is asking if then it opens a new perspective that patients with low clinical risk are also candidates for
Sorry, you are muted. I did not hear the question.
Sorry. It's a segue of the other question. Dr. Eduardo is asking if we open a new perspective of asking for this signature, for the MammaPrint signature for patients with low clinical risk to identify this ultra low. So this is another perspective on a new indication for this genomic signature.
Yes, I think that the ultra low or the foregoing of chemotherapy or endocrine therapy, you probably would not want to do that in patients that are clinical high risk. But in the clinical low risk population where you are not going to give chemotherapy because of the low risk, but you are wondering whether or not endocrine therapy is going to be beneficial, I think this is going to be the field of indication to use MammaPrint ultra low.
Yes, and another thing that was quite interesting in your presentation about the amount of patients in the screen population that was ultra low patients. And I don't know if you can make this conclusion or think about that. We know that there are a lot of patients that are detected on the screen programs are tumors that are not so threatening for the patients. So do you think that this the MammaPrint is identifying patients that we are actually maybe doing an overdiagnosis with the screening?
Well, screening in itself is already a very good prognostic factor, as we have shown, but also many others before us already. And indeed, we see that within the screen detected group, there are much more low and ultra low risk cancers. But survival of all patients was good in the screen detected cancer. So I think if you want to de-escalate endocrine therapy, that you are mostly going to focus on this group of screen detected cancers. Although on the same, or on the other hand, patients with interval cancers that we of course traditionally see as more aggressive cancers, if patients have a low or ultra low risk MammaPrint in that group, they also have excellent survival. So it's indeed MammaPrint can be used in both, but I think the screen detected group is going to be the group where the most benefit from de-escalation can be obtained.
And another question here from Dr. Carolina Vasconcelos. She's asking if the ultra low risk category group would be also able to de-escalate radiotherapy.
That's a very interesting question. And I think that that's also going to be an area of research in the coming years. I know that in the Netherlands, we already have trials where we are trying to de-escalate radiotherapy in women that are over 70 with low risk cancers. And so I think it would be very interesting to see if we could use MammaPrint for that as well. Currently, there's no trials investigating this, but it's definitely an interesting question.
Let me see if we still have another questions, but I think no. We are on time. We're recovering a little bit of time that we are running late with our program. So if we don't have any further questions, I would like to thank Dr. Josephine very much for her presentation and for participating in our program. Thank you very much, Dr. Josephine.